Thank you very much, Axis Medical School, for arranging a class on aortic stenosis. So we'll discuss today on valvular heart disease. And aortic stenosis is one of the valvular heart disease. It is a stenotic type of lesion. So welcome you all, and today's our discussion will be based on case-based and evidence-based also. So now let us start. So our first case is a 63-year-old gentleman presented several times of syncope with shortness of breath on exertion for last 2 years, increasing intensity for the last 3 months. And on examination, he is dyspneic, pulse 1 to 28 beats per minute, pulse is a small volume, and blood pressure is 90/60 mmHg. Respiratory rate is 32 beats per minute. There is systolic thrill in the aortic area and all over the precordium. ECG showed left ventricular hypertrophy, features of left ventricular hypertrophy, and chest X-ray showed there is cardiomegaly. And echocardiogram, that is the gold standard test that confirms the diagnosis of the severe aortic stenosis. And this patient is suitable for TAVI. TAVI is a one-type modality of treatment or management of the aortic stenosis. This is the intervention procedure. By this procedure, we actually replace the aortic valve with the artificial valve. And as it is done, trans vessel, that is without cutting the sternum. So it is an intervention procedure. So it is a trans-aortic valve implantation. And patient underwent TAVI, and TAVI was successfully done. Now he's doing well. So what we have learned from this case scenario, that is, first is a 63-year-old gentleman, that is aortic stenosis may be present in the older age. From here, we also learned that a patient with 63 years old may present with aortic stenosis, and obviously a patient with 63 years old, most likely in that cases, the cause is degenerative cause or senile cause. That is, the cause is due to aging process. Actually, valve is involved by aging process. There is thickening of the valve, and so valve is thickened, and there is a development of the stenosis. Stenosis means there is a narrowing of the valve, that is aortic valve. So a patient may present in the elderly age group, or a young patient may also present with this type of aortic stenosis. In that cases, we'll see later on what are the causes of aortic stenosis and what are the, in that cases, if a young patient present with aortic stenosis, in that case, we always suspect this patient may have bicuspid aortic valve, that is congenital heart disease, or this patient aortic stenosis is due to rheumatic process, that is sequelae of the rheumatic fever, that is chronic rheumatic heart disease. So in that case, if a patient present with aortic stenosis, in that cases, we always suspect this causes of this aortic stenosis may be bicuspid aortic valve, or there is a congenital cause or congenital aortic stenosis, or there may be due to rheumatic process. So, and if a patient present in elderly age group, in that cases, we suspect that this patient may have degenerative cause. So, so how a patient with aortic stenosis may present. From this case scenario, we have learned that this patient present with several times of syncope. There is sudden loss of consciousness for the transient period, and there is shortness of breath on exertion. Especially patient may present with this type of presentation, that is syncope. And in that cases, if a patient present with syncope, that indicates the patient has got severe aortic stenosis. The degree is severe aortic stenosis, and patient may present with shortness of breath on exertion. Even the patient may present with chest pain on exertion, or even patient may have chest pain even in the rest. Due to left ventricular hypertrophy, due to low output syndrome, the patient may present with shortness of breath. And obviously, the intensity of the shortness of breath or intensity of this syncopic attack or intensity of the chest pain may increasing in nature over the period. And the other things, actually, we have learned that in case of aortic stenosis, the patient may have a small volume pulse due to low output syndrome, and there is a systolic thrill in the aortic area, and this systolic thrill or murmur may be heard all over the precordium. So in case of aortic stenosis, the patient may have systolic thrill and systolic murmur, and that is usually present in the aortic area and may also present in all over the precordium. So this is systolic murmur may be heard all over the precordium. And obviously echocardiogram is the gold standard treatment, gold standard investigation by which we can diagnose the aortic stenosis, or we can establish the aortic stenosis, diagnosis of aortic stenosis, as well as we can see the severity of the aortic stenosis. That is, if the patient has got mild, moderate, or severe type of aortic stenosis. Because depending on the severity of the aortic stenosis, as well as depending on the symptoms of the patients, our management strategy varies. So in case of severe aortic stenosis, and if the patient has got syncope and the patient has got shortness of breath and exertion, in that cases, actually valve replacement is the answer. And if patient is feasible for transaortic valve replacement, that is TAVI suitable. And if the patient is not suitable for TAVI, or the patient may, if have aortic regurgitation along with aortic stenosis, in that cases, we can do the aortic valve replacement by surgically. That is aortic AVR, aortic valve replacement. So we have learned a lot from this case scenario, and also we have gained a lot of knowledge from this case scenario. So our second case is a 53-year-old gentleman present with shortness of breath on exertion for the last 2 years, increasing in intensity for the last 3 months. On examination, he is dyspneic, pulse 1 to 2 beats per minute, irregular BP 100 over 30 millimeter mercury, respiratory 32 beats per minute. There is a diastolic thrill in apex, and there is a mid-diastolic murmur in the apical area, early diastolic murmur in the left lower sternal area, and there is systolic murmur in the aortic area. That is, this patient has got 3 murmurs actually, and obviously one murmur is, there's a diastolic murmur in the left lower sternal area. It indicates the patient has got aortic regurgitation. There is systolic murmur in the aortic area that indicates the patient has got aortic stenosis, and there is a mid-diastolic murmur in the mid-diastolic murmur in the apical area that probably indicates this patient may have mitral stenosis also. So ECG showed there is atrial fibrillation, and we have also learned that a patient with long-standing mitral stenosis can present with atrial fibrillation, and chest X-ray PIV showed there is a cardiomegaly, and echocardiograph showed severe mitral stenosis with moderate aortic stenosis with severe aortic regurgitation with moderate pulmonary hypertension. Patient underwent DVR, that is double valve replacement. That is, in that cases, as this patient have mitral stenosis, severe mitral stenosis, as well as there is a moderate aortic stenosis, as well as severe aortic regurgitation. So as 2 valves, that is aortic valve as well as mitral valves, both are diseased and both are deformed. So in the same setting, double valve replacement was done, and this is the one of modalities of the treatment if the both valves are involved and both valves have severe stenotic or severe type of regurgitation type of lesion. So in that cases, DVR was done and patient is doing well. So actually, this is the case scenario. What we learned from it, we have learned that a patient may present with double valve pathology, that is mitral valve pathology as well as aortic valve pathology. And if there is a double valve pathology and if both valves are severely damaged, that is patient present with severe stenosis, or patient may present with severe regurgitation, in that cases, actually double valve replacement, that is to both valves should be replaced in the same setting. So double valve replacement was done. And now we go for details on the aortic stenosis. So this is the normal aortic valve. We have seen from this figure that there is 3 curves, and these are crescent shaped curves. There is 3 commissures, 3 sinuses, and these are supported by fibrous annulus. So this aortic valve actually, here we see that there is 3 curves, crescent shaped curve, 3 commissures, 3 sinuses, and these are supported by fibrous annulus. And the mitral valve, aortic valve area is normally 3 to 4 centimeter square area. This is the normal aortic valve area. And we have already discussed it, the anatomy. And this is the, we all know that there is a normal valve functions, that is that maintains the unidirectional flow of the blood, and obviously that prevents the reversal of the flow. That is, that prevents the regurgitation of the blood flow. Heart valves actually, they maintain one-way blood flow through the heart, as well as actually the valves within the vessels that also maintain the unidirectional blood flow. There is we all know that there are 4 valves. This is a tricuspid valve. That is, this is a tricuspid. There are cusps of 3 cups. This is bicuspid valve or mitral valve, and this is the semilunar valve 2. That is the aortic valve, and this is the pulmonary valve. This is the aortic valve actually. This is the pulmonary valve. This is the aortic valve. This is the bicuspid valve, the mitral valve, and this is the tricuspid valve or 3 cusp valve, tricuspid valve. And so, what are the parts of the heart valve? We have already discussed the last lecture. There are usually leaflets. There is a commissures. There is junction between the different leaflets, and these are the chorda, actually chorda tendineae, chorda, and this is the papillary muscles. Actually, these are the parts of the valve. Especially, actually, these are the parts of the tricuspid and as well as the mitral valve actually. This is the anterior annulus. These are subcommissures. This is the annulus. These are the leaflets, and these are commissures, and these are the chorda tendineae. These are the papillary muscle actually. These are the actually parts of the heart valve like annulus, commissures, chorda tendineae, and papillary muscles. So now we'll discuss what are the causes of valvular disorder. Already I have discussed a little bit about the causes of the valve disorder. That is causes of the different types of valvular lesions, and from the case scenario, that one case we have discussed, that the first case scenario is in a patient with elderly age group, and probably the cause is the senile degeneration or degenerative type of the cause of aortic valvular heart disease. So there may be congenital heart disease. We already discussed. There may be bicuspid aortic valve. Or there may be membrane also, aortic membrane, that may cause the aortic stenosis. There may be rheumatic heart disease. There is the sequelae of the rheumatic fever. So the patient may have aortic stenosis due to rheumatic heart disease. Or there may be some infections like infective endocarditis that can lead to the development of the aortic stenosis. There may be a heart attack also, and there may be weakening of the supportive structures of the heart. And these are another cause, a degenerative cause, that is the senile cause. And depending on the actually the duration of the dysfunction, we can classify the valvular lesions as aortic and chronic. We can also differentiate on the nature of the valvular dysfunction, either stenosis or regurgitation, or both type of lesion, that is stenosis and regurgitation may be present in the same patients. There is a degree of dysfunction, that is depending on the NIHA degree of cardiac dysfunction. There is the depending on the symptoms of the patients. That is shortness of the breath, that is the degree of the shortness of breath. We can also declassify the valvular heart disease. And so how actually we can diagnose a patient with valvular heart disease? So we should take the detailed history of the patient. We should do the detailed physical examination of the patient also, either general examination and systemic examination. There is examination of the precardium, and we should do ECG. ECG may give some suggestions, and chest X-ray also may have some clues. and echocardiography. This is the with color Doppler study, that's a gold standard study that can confirm our diagnosis, as well as that can give us the severity of the valvular lesions, as well as by echocardiography that can guide us what treatment actually a patient with aortic valvular disease or any type of valvular lesions should have the modalities of treatment actually. And these are some invasive evaluation like cardiac cath, and the patient may also need, in some cases, that is CT and MRI may also needed to see the condition of the valves actually. And how actually this patient usually present with aortic stenosis, we have discussed in two cases actually. In first cases, patient usually present with several types of syncope, several episodes of syncope. That is, syncope may be a presentation. And when patient present with syncope, usually in that cases, the severity is very, very severe actually. The severity of the aortic stenosis usually is severe. And if the patient may also present with shortness of breath and exertion, or patient may present with chest pain or chest pain on exertion also, or even patient may present with chest pain even in the rest also. So, or patient may be even asymptomatic when there is a mild aortic stenosis. So, this is the way actually patient present with aortic stenosis. Even patient may present with palpitations, or patient may present with fissures of heart failure, as patient is not treated in the proper time. That is, aortic stenosis is not addressed in the proper time. Patient may eventually may have fissures of heart failure, or patient may develop into the heart failure also, or left ventricular failure. So patient may present with left ventricular failure. So on physical examination, we should scout for if there is a murmur, that is actually systolic murmur, and the systolic murmur usually we found in the aortic area, and also the murmur may present throughout the whole precordium. There may be peripheral edema, as the patient may present with heart failure. There may be lungs, tracheal, elevated JP. These are the actual features of heart failure if a patient is not or aortic stenosis is not treated at the proper time, or patient is not addressed in the proper time. There may be displaced apex beat or irregular heartbeat. Irregular heartbeat may present if the patient has colorectal fibrillation, and displaced apex beats if the patient has aortic stenosis with aortic regurgitation, or there may be left ventricular hypertrophy, or there may be pathology with other valves that can displace the apex beat. So these are the actually aortic stenosis. This is the murmur, that is murmur of the aortic stenosis, and this is the aortic area, and the murmur of the aortic area, that is systolic murmur, usually best heard in this aortic area. And these are the causes of actually aortic stenosis. That is the degenerative aortic stenosis that we have actually discussed in the first case, bicuspid aortic valve. If a young patient may, in the age of 20 or 30, in that cases, usually we suspect this patient may have congenital aortic bicuspid aortic valve, or patient may have a rheumatic heart disease, or congenital aortic stenosis, that is unicuspid aortic valve. There may be rheumatic heart disease, that is the sequelae of the rheumatic heart disease that leads to the development of the aortic stenosis. Patient may have cause of infective endocarditis that causes the aortic stenosis also. There may be some rare causes like post-radiation. There may be associated with some systemic diseases that can have aortic stenosis also, like ankylosing spondylitis. Though in patient with ankylosing spondylitis, usually aortic regurgitation is present, but aortic stenosis may also be present. So this is the normal aortic valve. This is the rheumatic type of aortic stenosis. This is the calcified type of aortic stenosis that actually usually we found in a degenerative cause, that is a elderly age group. And this is the bicuspid aortic valve actually. Usually we found this type of bicuspid aortic valve in a young patient, usually when a young patient present with fissures of aortic stenosis. This is actually the normal aortic valve. We have valve area actually 3 to 4 centimeters square. And when we call mild aortic stenosis, that is when area is more than 1.5 centimeters square. There is a moderate aortic stenosis when there is a 1 to 1.5 centimeters square, and severe aortic stenosis if the aortic valve area is 8 to 10 centimeters square. This is the classification of the aortic stenosis severity depending on the gradient actually, mitral valve gradient. Sorry. If the mean gradient actually less than 20, then we call this mild aortic stenosis. If the mean gradient is 20 to 39, then we call it moderate aortic stenosis. If the gradient is more than 40, then actually the severe aortic stenosis. If the patient present mitral aortic valve gradient, aortic valve more than 60, then it is very severe aortic stenosis actually. Aortic stenosis actually may be valvular, or maybe supravalvular, or maybe subvalvular. That is, pathology may be in the aortic valve, or pathology may in the above the aortic valve, or pathology may within below the aortic valve. That is subvalvular. Actually, if a patient present with aortic stenosis, so there is obstruction of the ejection of the blood from the left ventricle into the aorta. So there is an increasing gradient between the aorta and left ventricle. And so there is a progressive hypertrophy of the left ventricle. And this progressive hypertrophy of the left ventricle can lead to the development of the also left atrial enlargement to the later on. And if the patient is not treated in the proper time, in that case, this patient may also present with there is maybe left ventricular dilatation, or then patient may present with features of left ventricular failure or heart failure. Even patient may present with, as there is a hypertrophy of the left ventricle, there is a relative ischemia, and also patient may present with ischemia, myocardial ischemia of the left ventricle also. These are the presentation we have already discussed. Patient may present with chest pain, patient may present with syncope, or patient may present with shortness of breath on exertion. And even patient may present sudden cardiac death, as there is a hypertrophy of the left ventricular muscle. Or patient may present with left ventricular failure also. So there is a risk of the sudden cardiac death also. And this is the aortic stenosis, murmur of the aortic stenosis. This is the slow rising. There is a slow rising carotid pulse. That is pulsus tardus, and decreased pulse amplitude. There is a pulsus parvus, and there is a crescendo decrescendo murmur. This is a crescendo decrescendo murmur with maximum of the right sternal border, second to third intercostal space propagated to the carotid arteries. The loudness of the murmur is not directly correlated to the severity of the stenosis. And heart sound usually. Faster sound, there is actually there is no change in the faster sound, but there is a soft and split second heart sound, and there may be present of the fourth heart sound due to the left ventricular hypertrophy also. These are the bicuspid aortic valve actually. This is the pathology of the bicuspid valve. This is the bicuspid aortic valve. There is a distal and there is a systole position. There is subvalvular aortic stenosis. There is actually membrane, and or there is a fibromuscular ridge that can causes the left ventricular outflow tract obstruction, and patient may have features of the aortic stenosis. There is a supravalvular aortic stenosis. There is also some membrane. Then this membrane actually present with features of aortic stenosis. But pathology lies above the aortic valve. And what are the actually treatment modalities of the aortic? We have already discussed that there is two actually modalities of aortic stenosis. That is one TAVI, and this is the interventional procedure, and the other is aortic valve replacement, that is surgical replacement. And if the patient present with mild aortic stenosis, in that cases, mild aortic stenosis, patient may present, patient may don't need any, that is only medical treatment may be necessary. Even patient may don't need any type of actually any type of in case of if there is a mild aortic stenosis, actually no treatment may be needed. That's medical treatment is enough. But TAVI, that is transcatheter aortic valve replacement, transcatheter aortic valve replacement, are in aortic valve implantation and aortic valve replacement. These are the two actually models of treatment. But in some cases, the patient may need, in case of especially congenital aortic stenosis, patient may be benefited by percutaneous aortic balloon valvoplasty, like PTMC. We can also do, there is a balloon valvoplasty of the aortic valve, and in that cases, patient may have some benefits, especially there is a bridging therapy like in unstable patients, or there is a congenital aortic stenosis. Indication for replacement, when we have already discussed, if the patient has got severe aortic stenosis, and even the patient has got symptomatic, like patient has syncope, patient has shortness of breath, or patient has got chest pain, in that cases, or there is a LV function decreases, in that cases, that is aortic valve at the 1 centimeter square, and there is a mean gradient is more than 40 millimeter mercury. That is the indication for replacement of the aortic valve. And if the patient has moderate stenosis, in that case, that is aortic valve area 1.5 to 1 centimeter square. And if the patient has got symptoms, in that case, aortic stenosis, aortic valve replacement may be done. These are the actually, then maybe in case of aortic valve replacement, there is usually two types of valve we can use to replace the aortic valve, that is mechanical valves, and there is a tissue or biological valves. These are mechanical valve, these are the tissue or biological valves. And in case if the patient is young, in that cases, and the patient don't need any, and what are the actual advantage of the metallic valve and the biological valve? The biological valve is less durable. That is, usually it can degenerate or it can be destroyed after 5 to 10 years. But mechanic valve is more durable. But when mechanic valve is replaced, in that cases, proper anticoagulation is necessary. But in case of biological valve, in that cases, anticoagulation is not needed. So these are the advanced and disadvantages of these two types of mechanical and tissue valves. So I think we can stop here. So today we have discussed aortic stenosis, and we have discussed the two case scenario and how we have managed these two cases we have already discussed, and we have also details how a patient with aortic stenosis can be presented, and how we can diagnose or we can confirm a patient with aortic stenosis, and how we can manage a patient with aortic stenosis. These are elaborately discussed today. So I think we can stop here today.